all of us feel these is rare diseases that we are dealing with, but they are not so rare. Almost 20 to 25% of blindness in the working population is because of inherited retinal degeneration. And the new standard of care involves early diagnosis, characterization of disease, genetic testing, and familiarity and up-to-date knowledge of the ongoing clinical trials. Clinical characterization involves history, visual acuity, perimetry, multimodal imaging, and electrophysiology. And the vision will not only just be BCVA, but also refractive error, color vision, nystagmus, all these will be necessary. Fields, though we are not, as a retina specialist, we don't give too much importance, but here where inherited retinal dystrophies are concerned, they are very, very useful not only for diagnosis, but for knowing the progression of disease. And electrophysiology, which is forms the basis of diagnosis of IRDs, I'm just giving it in a single slide as an overview as to how this, along with multimodal imaging, can lead you to the diagnosis. And in this era of wide field fundus photography, this is the most vital investigation because it is helpful in documentation and looking at the follow-up of these cases. You can see here that if I just take the fundus photograph, we will probably miss a lot of pathology, which is very easily seen in cases of wide field photography. And fundus autofluorescence, you can see the top Mirante image. It does not show too much as to how much is the extent of disease, but is beautifully delineated on fundus autofluorescence. Some of the diseases will have a characteristic feature of ABCA4, which is peripapillary sparing of the RPE. So here, in most of the RP patients, you will have this ring which is present, and this ring is suggestive of the dying cells. It corresponds to the ellipsoid layer which is present here. And X-linked photoschisis, you can see that autofluorescence, if it is involving most of the area of schisis, it usually means it's an advanced nature of disease and it will not benefit by surgical intervention. OCT in IRDs can help you look at the prognosis as well as presence of macular edema, which is present or not. And a lot of the diagnosis of macular dystrophies, including the Best disease, can be done based on OCT. Presence of associated higher reflective foci can be also a prognostic sign. And in gene therapy, what is also important is the EZ width, which is present or not. Good phenotyping can help you even understand what gene are you looking at, because if you have these typical features of an annular ring and schisis on OCT, along with a typical ERG, you know it is the NR2E3 gene that you're looking at. And if you see cone dystrophy with these supernormal responses, you know that it is the KCNV2 gene which is known to cause cone dystrophy. Other tests which are also used include dark adaptometry, adaptive optics. And coming to genetics, how do you work on the genetics of these cases? First of all, you try to do a family pedigree and look at whether it's a recessive gene, dominant, X-linked recessive, or X-linked dominant. Almost 300 genes are known to cause IRDs, and genetic testing is the new standard of care. As early as 2016, AO has given this task force that all cases with monogenic diseases such as RP and Stargardt's must undergo genetic testing, and genetic testing is particularly useful where the FDA approved gene therapy like Luxturna is already there, and if especially you suspect autosomal dominant or X-linked disease, which can be very severe, genetic testing is very vital. As was previously touched upon by the previous speaker, we saw that you could order a whole genome sequence, a panel gene, or a single gene. A single gene is more not very practical. So it's a gene panel which is ideally suited, because the whole gene exome can be very expensive and give you a lot of unnecessary information which you may not be able to clinically relate to. So gene panel reduces the cost and helps the results come within a month, and that can give you establish a good genotype correlation, understand the clinical diagnosis, appropriate follow-up, as well as give accurate prognosis to these cases. So both molecular diagnosis and good phenotyping is necessary in these kind of cases. This is a typical presentation of circle mutation, and this was another case that we recently saw, and a patient had macular atrophy, but when I saw the periphery, it had this kind of a well-demarcated area of coin-shaped lesions, and having known that circle could present like this, even in the absence of night blindness, we got genetic testing done, and it was definitely a circle which was a pathogenic gene mutation. But on the other extreme, this is a known case of RP. We know everybody can see that this is retinitis pigmentosa, but genetic testing did not reveal any known gene. So it is not always, this is another example of USH2A. This is a combination of good phenotype as well as genetic testing which can give you the result. So once you have decided that this is the genetic testing and you have done it, what next? Genetic testing comes with a lot of responsibility. You have to have a geneticist with you who can do adequate counseling, and the counseling is needed to be both pre-test as well as post-test counseling. Pre-test in which the family pedigree can be done, mode of inheritance can be explained, the nature and the limitation of these genetic testing should be discussed with the parents, because they would expect that once you have done the testing, now the child is going to be cured. It is not like that. So this is very, very important. And genetic counseling can be, both for the prognosis of the child as well as future offsprings. Just to touch upon the treatment, symptomatic in form of low vision aids, and these associated problems which can be seen in IRDs like choroidal neovascular membrane or macular edema will need to be treated symptomatically, either in form of anti-VEGF injections or in form of carbonic anhydrase inhibitors. So this is sometimes when you need a surgical intervention as well. And this is a patient of Jacobson syndrome, which is a chromosomal 11 deletion, and chromosome 11 also harbors the frizzled gene, which is responsible for FEVR. And this was the patient that I saw had operated because of FEVR, the patient had bled, so the blood had to be removed very carefully. And once it was done, there is visual rehabilitation, but because of the other associated anomalies of chromosome 11 deletion, the patient also had autism, dysmorphic faces, behavioral problems, and VSD of the heart. So multiple problems have to be dealt with some of these cases. Pharmacotherapy in form of antioxidants and vitamin A, and we know that finally it is apoptosis which leads to pre-programmed or early cell death. So a lot of anti-apoptotic agents have been used, including the basic fibroblast growth factor and other neutrophins, which can reduce the rate of cell death. So largely treatment of IRDs is in the basis of gene therapy, stem cell therapy, optogenetics, neuroprotective agents. So I think gene therapy will be covered by the following speakers, but it can be in form of augmentation or CRISPR technology in gene editing. And lastly, ocular prosthesis for end-stage disease. Argus 2 ocular prosthesis has been used, but with limited benefit because a lot of complications associated. Knowledge of the clinical trials, so just to enumerate that we have clinical trials going on for USH2A, for choroideremia, for XLRS, for achromatopsia, for Merck-associated RP. So definitely these are the genes which should be, when suspected, patient should receive genetic testing and counseling. So to conclude, retina specialists need to remain up to date to their knowledge of the current and genetic testing methods and all the clinical trials which are happening. And targeted gene therapy has the potential, but it's not the only way to treat gene IRDs. And with that, I conclude my talk. I think this is just a beginning to a lot more work which is going to come very, very near future. I don't think it is very distant now. Thank you.
Thank you, Dr. Praveen. That was a very illuminating talk, and you touched upon very important aspects of genetic counseling. And I think our subsequent speakers will also cover it. Next, I would like to call upon Dr.